consider for a subclavian line. And this is our clavicle here. You see our sternocleidomastoid and our central vessels here. So we've got superior vena cava, brachiocavalic, and this is the subclavian vein. And we will be using a landmark technique for this predominantly in a traumatic scenario such as a traumatic cardiac arrest. We will want to find the S-bend of the clavicle, which is hard to see in this picture, but it will be about the lateral 2/3 point, so where the lateral third meets the proximal 2/3. And we will want to sneak our needle in under the clavicle and try and hit the vein either here in the subclavian or as it bends back down to enter as the brachiocavalic. Of note, the artery is deep to the vein, so if we hit clavicle and go immediately beneath it, we will almost always hit vein before we hit artery, providing a bit of safety from an intra-arterial stab. From an external anatomy perspective, we need to be aware of the clavicle, the superior border of pectoralis, and also the deltoid. And we're going to insert our needle in this triangle, so the clavi-deltopectoral triangle. And then at that point, we're going to angle towards the suprasternal notch. And the location that we're going to be trying to get in under is where the lateral third of the clavicle starts to bend towards the medial third. So the technique tends to be talked about with a non-dominant hand index finger in the superior suprasternal notch, the thumb of the same hand on the S-bend of the clavicle, and then my finger will represent where you're trying to get your needle into the triangle that we talked about, clavi-deltopectoral. And then we're going to advance along the line of the thumb and finger, initially hitting the clavicle, and then drawing back just a millimeter before pushing down the needle. So if we went in like this, we've hit the clavicle, we draw back a little bit, we push the needle down with the thumb, and we continue flat along the surface and parallel with the surface of the skin, aiming for this suprasternal notch as if it's like a snooker cue. We would want to have sterile gloves, chlorhexidine swabs. We have the MatLine kit itself, and then we, for our kits, need a percutaneous introducer needle, which comes separately to the MatLine kits. This one is still in date, so we're not going to use that, whereas this one is out of date, and this is what the needle looks like if you take it out of the packet. So you will take it out of the packet, ensuring you have your sterile gloves on. It might be wise to swab the area before you get your sterile gloves on and start preparing your gear, so that's drying. And put a 10 ml syringe on that, have that ready, and now we're going to prepare the line itself. So you'll carefully open your MatLine and put everything on its packaging. And then the first thing you'll notice is that the introducer sheath is the wrong way, so you'll have to turn that around and push that into the hemostatic bung at the back of the line and load that all the way through. At this point or prior to that, you can prime the line with normal saline. That will prevent an air embolism. And then lastly, you're going to get your wire, and you're going to bring the nib of the plastic nib, which allows you to direct the wire into the back of the introducer to make sure that this is straight. So just draw that across the tip, so only a millimeter of the tip is visible, and lay that on your sterile surface. From a technique perspective, we'll identify the landmarks as we talked about before. So suprasternal notch, S-bend in the lateral third of the clavicle, clavi-deltopectoral triangle. We're going to, so into the skin, identify your landmarks, push forward while aspirating until you hit the clavicle along the line of your thumb and index finger. The thumb's going to be at the lateral third of the clavicle at the S-bend, and the index finger is going to be at the suprasternal notch. Once you hit the clavicle, push down, keeping the needle parallel and along that trajectory, and start to go just underneath the clavicle. You can pull back a millimeter after you've hit it, and then pushing down the needle with the thumb, and then continue to push that down. And now you're under, you can make sure it's straight and flat to the chest, and making sure you're putting good suction in while you're lining up the clavi-deltopectoral triangle until you get your flashback. And then once you get flashback, hold your needle nice and still. Remove your syringe, Make sure you have everything close to hand. At this point, we're going to enter your guide wire. Once you've got the needle out, pinch the guide wire near the skin, remove the needle completely. And then at this point, it's time to load up the MAC line onto the guide wire as any normal modified cell dinger would. And then you might have to put a little bit of traction in the skin, make sure the guide wires came out the back and it's still moving freely. A little bit of traction on the skin, push through. Might need to do a bit of a twisting motion. These mannequins can be a bit sticky. Up to the hilt. And then remove guide wire and remove the sheath at the same time. And then we're going to check we've got it in the right place.
Hi, I'm Jeff, and we're going to touch on some of the points of ultrasound and how you can use that as an adjunct to performing your subclavian central access. Going back over the surface anatomy again, we're looking for the medial border of the deltoid, the superior border of the pec major, and the inferior border of the clavicle. We're going to use our linear probe. And as this is a vascular access procedure, we'll obviously be using our vascular access mode on our ultrasound at a depth of about 3 to 4 centimeters. Starting on the more lateral aspect of the clavicle, you'll identify the axillary vein and track that in an out-of-plane technique, moving medially and superiorly until you see it become the subclavian vein. To the left of screen there, you'll see the clavicle, and the shadow cast by the clavicle. And the subclavian vein will continue superiorly and inferiorly beneath the clavicle. Coming back more laterally now, you can then rotate the probe again, an in-plane view of the subclavian vein.
In summary, we've had a conversation about anatomical landmark subclavian central lines for large bore access like a MAC line. So go out there and smash it.